Hola, buenos días. Gracias por continuar aquí. Y para continuar con el programa, vamos a hablar de un tema, pues, por demás interesante. Quisiéramos que muchos de los pacientes se presentaran como ahorita nos acaban de decir, en enfermedades tempranas. Desafortunadamente, el cáncer de páncreas se presenta en la mayor parte de los pacientes en etapas avanzadas y hemos visto la evolución de la quimioterapia y actualmente la tendencia hacia nuevas moléculas. Es por eso que, yo soy la doctora Maritere Herrera, soy oncóloga médica del Instituto Nacional de Cancerología y para mí es un placer también presentar a la doctora O'Reilly, que nos comentará sobre toda esta evolución y sobre pues cuáles son estos nuevos agentes y cuál es la tendencia actual en el tratamiento. Muchas gracias por estar aquí.
Great. Well, thank you very much again for the introduction, and once more, it's a pleasure to be here this morning. So we'll get going. So the topic is advanced pancreas cancer, from chemotherapy to molecular targets. And hopefully I'll get this right this time. So just acknowledging disclosures and a number of off-label uses in terms of medication. So this is the agenda. Just going to give a brief state of the art in terms of where we are, to discuss genomic testing, both germline and somatic, in pancreas cancer, and to discuss how that's being integrated into treatment for this disease, and then just a brief summary of what's happening in other spaces in terms of novel therapies for pancreas cancer. So I know these data are known to many, but I just want to point out a couple of things. So the incidence continues to slowly increase in this disease, but one of the important benchmarks that was observed in 2020 was that for the first time, taking all comers with this disease, that 5-year survival has approached 10%. That's obviously nothing to be proud of, but that's moved slowly but surely over the last decade, which I think is a consequence of the integration of new therapies in this disease. But clearly we have much work to do. And then one of the other kind of curious but troubling epidemiologic factors is that the incidence of pancreas cancer is changing. This slide was taken from an article in the Lancet Public Health, which shows that the incidence of pancreas cancer in older people is stable, and that's been so for many decades. But where we are seeing an unsettling trend is in younger people. So if you look here, for people in their 30s and 40s, we're seeing a little bit of an upsurge in this disease, and that's possibly due to lifestyle considerations, due to the obesity epidemic, due to diabetes, and probably multiple other unknown factors. But that's something that's worrisome and something that we need to think about changing. And not to overstate this, still this disease is most common in older people. So here's where we are in 2020 for pancreas cancer. It's dominated by cytotoxic therapies. These are approved treatments in North America. The red boxes speak to agents that are approved in a targeted setting. And just a brief reminder, erlotinib that came up in the questions section a minute ago, this was approved in a non-selected setting almost 20 years ago now, not quite. But more recently, pembrolizumab for the subset of MSI-high pancreas cancer, for a subset of people who have larotrectinib and entrectinib who have NTRK fusions, and more recently at the end of December 2019, the approval of olaparib as a maintenance treatment in the setting of germline BRCA1 and BRCA2. So if putting up schematically, sorry, the colors don't project so well here. You can see that it's cytotoxic therapy across the spectrum here, but just to emphasize, and we'll review the data supporting this, that essentially for all patients now with advanced disease in our guidelines, NCCN and forthcoming in ASCO guidelines are the recommendation for molecular sequencing, both at a germline level and in the tumor for these patients, in that it's very important to identify the subset of people who may benefit from a targeted approach. So we touched on this briefly in the debate or in the discussion, is we have two main treatments in the frontline setting. As yet, there's no direct head-to-head comparison. In fact, the first data that will directly compare these will come from a SWOG study, S1505, which looks at these regimens in the neoadjuvant setting, and that will read out next year. But if you look at all the real-world data, it's a pretty consistent theme that FOLFIRINOX, in general, tracks superior to gemcitabine and nab-paclitaxel when you match patients for patients, and statistically these numbers are not different, but that consistent observation is there. I'm sorry, just going back one slide, excuse me. So these were data from a cooperative group in North America looking at the addition of PEG-PH20, so pegylated hyaluronidase. As people may be aware, this trial read out negative in the setting of gemcitabine and nab-paclitaxel, and I show it here for two reasons. One, that it's the best survival in an unselected patient population that we've seen in a academic and community-based setting in pancreas cancer, approaching 14 months in this disease. The other surprising and unexpected point was that patients who received the experimental agent clearly did worse and had more toxicity and an inferior survival. So that drug, unfortunately, is not moving forward, but it certainly wasn't moving forward with FOLFIRINOX. So what about maintenance treatment in pancreas cancer? So we have some data speaking to it in unselected patients. This trial was presented almost 2 years ago at ASCO, still waiting for the final manuscript. This looked at people who received FOLFIRINOX and looked at de-escalating FOLFIRINOX to maintenance 5-FU or stopping after 6 months versus an alternating regimen of FOLFIRI and gemcitabine. And just that latter regimen was a bust and isn't moving forward. But the data were supportive of the strategy that's been adopted in the colorectal cancer world for many years of Optimox approach of de-escalating therapy and removing the oxaliplatin, that it doesn't compromise outcome. You will see that there's ultimately more neuropathy. That's because patients ultimately got more oxaliplatin in that they received it when they recurred. So moving to germline and somatic testing, these data are well known. This is one of the first larger genomic analysis in pancreas cancer that indicates that the key driver genes are KRAS, P53, SMAD4, and CDKN2, none of which right now are directly actionable. There may be a small subset of patients with a 12C mutation in pancreas cancer, maybe 1%, that may benefit from some of the new drugs that are being looked at in the clinic. We don't have data yet to speak to that. This is an analysis from the Know Your Tumor program. This was supported by the Pancreas Cancer Action Network to facilitate the early integration and use of somatic or tumor-based testing in this disease. And we may quibble with the results here, but nonetheless, this was an impressive effort. The investigators indicated that about 50% of patients had actionable findings. I think that's a very, very, very generous interpretation. But there's probably a good quarter that do, and those are the ones that are highly actionable, in particular represented by DNA repair gene alterations and the other rare subsets. So this is a subgroup I want to emphasize, and this is why we argue in favor of considering genomic testing. So in younger people, we see an enrichment of KRAS wild-type tumors, and I'll show you that data in a moment. It's about 6% in an unselected population. It may be 15-16% in younger patients with this disease. And the key thing here is that if you don't find KRAS, and it's not a limitation of your testing, so if you see other mutations and no KRAS, it's probably real. If you don't see any other alterations, it's probably a testing limitation. Then look for other oncogenic drivers here that may be underpinning the disease. So BRAF, HER2, ROS, ALK, etc., NTRK fusions. These are present in quite a number of patients with a KRAS wild-type tumor. And there are a number of drugs, a number of trials out there, and some of these accessible on an off-label basis. So this is just one example, NRG1 fusions. They're found in mucinous types of lung cancers, in biliary cancers, and in about maybe 0.5 to 1% of people with pancreas cancer. And this is targetable. This is using afatinib. This was from a publication in Germany, but there have been several other reports where you can see nice responses. And of course, these drugs are in general nicer for patients, less toxicity, some of them oral, some of them monoclonal intravenous antibodies. But think younger people, think KRAS wild type, think alternative actionable targets. So moving to germline testing, there's a lot of data now speaking to this topic. These are some of the most recent subsets from all the major cancer centers, indicating that the pickup rate of pathogenic germline alterations is probably around 10%. In some, it's more, but if you look at more genes, you'll find more findings. Not all are particularly relevant to this disease. In others, it may be less, but 10% seems to be a real number. This is the spectrum of alterations that we see. About half are BRCA1 and BRCA2, so about 5, maybe 6%. An additional percent PALB2, and then lower frequency other mutations like ATM, etc. And a percentage of these have actionable implications. So does it matter if you have a germline alteration irrespective of treatment? This is a relatively crude analysis, but there's other data speaking to this. You probably do a little better. That might be in part because in general you're a little bit younger. This doesn't tease out the predictive effect of treatment versus the prognostic effect of having the germline alteration, but the suggestion is these patients may do a little better. And in 2019, the NCCN updated their guidelines to recommend that germline testing be considered for all patients, and this is irrespective of age, ethnicity, personal history, or family history of this disease. They didn't give an exact recommendation of what that composition of the panel should be, but there's probably about 12 core genes, including BRCA, including Lynch, ATM, etc. And also came out with a recommendation for patients with advanced disease, which is essentially 90% of people with pancreas cancer, that somatic profiling should be considered. And this is where the challenge, especially in the locally advanced patients, of tissue comes up, and whether liquid biopsies may be a substitute. And again, I would say we're not there yet, but this is clearly emerging. So lots of ways to do genetic testing, and the old paradigm of the oncologist referring the patient to the genetics counselor didn't work. The trajectory of the disease and the complexity of treatment, decision-making, and all that this disease encumbers means a lot of patients just didn't get there. So now the way we do it, and this is modeled from our ovarian cancer group and our prostate cancer group, is we, as oncologists, do the initial counseling. We use a video educational tool along with verbal discussion, and then if there's a positive finding, we as the oncologist relay that to the patient, and then they will see the genetics counselor on the back end. And this has revolutionized our ability to do this, and has essentially allowed pretty much universal testing in the clinic. There are a lot of points to note, and we had a discussion coming over here about 23andMe, but just a reminder that some of these commercial entities are imperfect and do not look for all the key genes that are important from a family and from a treatment perspective. So you need one of the well-established and well-validated panels. Of course, there are lots of challenges with this. It's access, it's cost, it's reimbursement, patients' acceptance, its variants of unknown significance, and all of these that are still to be solved. So speaking to the question of microsatellite instability in pancreas cancer, we see about 1%, some others a little bit higher, and they are associated, those patients, with response to immunotherapy. We've seen that in other disease types. We know that these patients have a high mutational load, and we know there's a subset of patients between the average individual with pancreas cancer who has a low mutational burden that may benefit from immunotherapy. That's still being looked at, and there are probably people who benefit from combination rather than single-agent approaches. So Anna Varghese from our group just presented these data, the next one, at the Gastrointestinal Cancer Symposium last month, looking at the early onset group, so patients diagnosed before 50, and their outcomes were probably around the same overall, but we don't have a matched cohort as yet to say that for sure. But I just want to speak to that second bullet here, somatic profiling. 17% had a KRAS wild-type tumor, and at least half of those had an actionable finding. So again, just to kind of drive that point home of how important this is. And also looking at the germline testing in this population, about a third had a pathogenic germline alteration enriched in BRCA, but also other important genes, including Lynch, ATM, and PALB2, all of which have implications for family and for treatment. So current recommendations are to test everybody, and speaking to the question, we know that if we enrich, we'll find more likely, but if we keep out the age, the ethnicity, the personal history, and family history, if we were to go by conventional testing guidelines from previously, we'll miss about 40% of people who'll have an actionable alteration. So that's why universal testing is the recommended strategy. So moving for the last couple of minutes, just in terms of the treatment implications from this, and I think these data are well known to many. This is establishing the proof of principle that germline BRCA can be targeted in pancreas cancer. This is the POLO study, randomized phase 3, olaparib versus placebo, for those who had had platinum-based therapy for a minimum of 4 months. This was positive in terms of progression-free survival. It was not positive with regard to overall survival. And one of the critiques of this study is that the comparator here was not chemotherapy, which we know, of course, is active in this disease. But nonetheless, it does provide an option for de-intensification of therapy, switching to an oral agent with some quality of life advantages, or at least maintenance for people as an option in this setting. So this is now getting integrated into practice in pancreas cancer. The POLO study looked at the pure of the pure, so the canonical BRCA1 and BRCA2 and germline only. It did not speak to somatic data, it did not speak to PALB2, and we are waiting further data. So these are some other data that came out at GI ASCO, looking at combination chemotherapy with platinum and adding a PARP inhibitor up front. The hypothesis being that maybe PARP plus platinum can increase response, increase survival, and delay resistance. While we didn't see that, we did see that this was a very active regimen for cisplatin gemcitabine with or without veliparib, that this is not a typical waterfall plot that we see in pancreas cancer, and saw nice survival, again, in this selected germline BRCA1, BRCA2, and PALB2 cohort, suggesting that platinum and gemcitabine represents an alternative to FOLFIRINOX and a reference regimen to build on. I'm not making the claim here that it's better than FOLFIRINOX, but it's an option certainly for patients who are less robust. And additional analysis speaks to this fact that if you select the right patient, you can maybe really enrich for benefit, in that not just reporting 2-year survival, but almost 20% of this population with metastatic disease primarily were alive at 3 years. So again, speaking to the fact that we need to know these patients. So this is one additional retrospective analysis from Wongi Park, sorry I don't have his name here, who did a very nice look that hopefully we'll see out soon, indicating that it matters what your genomic subtype is with regard to the treatment choice in terms of outcome. And for patients who have DNA damage repair gene alterations, we want to make sure they get a platinum drug, and we want to increasingly make sure they have access to a PARP inhibitor. Those purple lines speak to that. Obviously, caveats here in that this is retrospective, but again, it's supported by the hypotheses that are present and other emerging data in the field. And building on the POLO data, this is a trial that we're going to open in a couple of months, which will look at immunotherapy plus PARP inhibitor in a group of patients who have DNA damage repair gene alterations, the core genes, and then all of the other genes where we're trying to understand if there's a signal, along with a subset of patients who have an excellent response to platinum-based therapy. We all see these patients, but we don't find an underlying genetic underpinning, and maybe they're a group also that could benefit from PARP inhibitors with or without immunotherapy. So just summing up what else has happened in view of time here. In terms of cytotoxic therapy, nanoliposomal irinotecan is being integrated as a FOLFIRINOX alternative and compared to gemcitabine and nab-paclitaxel. That's an ongoing phase 3, probably will read out in a couple of years. The whole theme of metabolism is an interesting one in pancreas cancer. There are several drugs that are in phase 3 testing, a drug called devimistat, or CPI 613, and eriaspase, which is an asparaginase inhibitor that's encapsulated in red blood cells. They've been looked at in the first line and second line, respectively, these two agents. Going back to the topic of immunotherapy, there's, I think, a disproportionate number of trials compared to the signal that we've seen so far, but perhaps one area where there may be a signal is adding immunotherapy to chemotherapy. We had some data read out at AACR last year on this topic, and a large randomized phase 2 has completed recruitment that will speak to adding checkpoint inhibitors and other tumor modulating agents in terms of the microenvironment, in terms of trying to influence T-cell activation and influx. And of course, building on this whole story of DNA repair in pancreas cancer. So summing up, a lot going on in novel therapy development in this space. We now have some biomarkers and a couple of validated biomarkers for treatment decision making, and we need to build on this and expand this to a broader population of patients. If I haven't said this 5 times already, and my apologies, I'll just restate it. So germline and somatic testing for all in this disease, and then thinking about those rare subsets. They are rare, but for that individual patient, it's very important. And as one of my colleagues nicely says, if you don't look, you won't find. And that's true, and that's very important. I think a big question mark in terms of the whole story of stromal modulation in this disease and immune therapy. We still have to wait to see how all of this pans out. So thank you. I'll stop there.